Good evening, everyone. I welcome you all to the latest webinar of Indian Society for Pediatric Cell Therapy and Transplant, SPECT. And as you know, every month we do these webinars, which are very educational for young trainees and young consultants across the country. And we try to get the topics which are very, very important in their practice. And as transplanters, there is nothing more challenging than chronic graft versus host disease, which we see and which we need to manage, whether we like it or not. And it's really test your patience and the quality of life of the patient. And sometimes it can be fatal also when it's severe. So this is something which I would encourage all the youngsters to log in and listen to this talk and this webinar and later on the panel discussion, because it would raise a lot of questions and it would make them rethink their practice. Because most of the young consultants or trainees, they have had exposure of 2 to 5 years in pediatric transplant, and that's not good enough to have an experience of managing chronic GvHD. And recently, in last decade, in India, we are doing more haplo transplants and more mud transplants and even TCR alpha beta depleted transplants. So we are seeing quite a bit of chronic GvHD in our practice. And many of us are not prepared to pick it up. And these patients have already gone into community by the time they're beyond day 100, by the time they start developing these symptoms, and quite a number of them might be international patients who have gone to their home country. So the first challenge is to pick it up timely, and the second challenge is to treat it properly. So today's webinar is all about that, and without taking much time, I would invite today's chairperson. So Dr. Ruchira Mishra is the chairperson for today's talk. And Ruchira was my student way back in Gangaram Hospital, and then she was a colleague at Fortis and Medanta, and we worked together. So now she was based in Mumbai and MRR hospital there, but recently she has moved to Dubai and might be joining some hospital in Dubai soon. So Ruchira, welcome you to today's webinar, and please introduce today's speaker for this. Thank you.
Thank you so much, sir. It's an honor to introduce Dr. Prashant Hivarkar for today's session. Prashant and I were one of the few who worked together to start the transplant program, a very successful transplant program in Mumbai. Prashant is a specialist consultant in pediatric hematology, oncology, and bone marrow transplants. He has a very, very big experience behind him. He did his MBBS from University of Mumbai and then further trained in England. He's had work experience at Birmingham Children's Hospital as well as the Great Ormond Street Hospital. So has really worked in good hospitals there. And then he also started the bone marrow transplant program at Wadia Children's Hospital in 2018. And one of the few hospitals to do a large number of transplants over a very short period of time with a very good success rate, even though it is a trust-based hospital. Prashant's also very, very keenly involved in research and academics and has a lot of publications to his credit. In fact, a lot of research and recent molecules being used in India and being published with their success stories can be attributed to Prashant and his team. So, Prashant, welcome to this seminar, and we hope that you'll be able to throw some light on chronic GvHD, because that's something that we face. Even though transplants are successful, the children will land up with morbidity, and that's something we don't want for our kids. We want them to have absolutely hospital-free visit, and it's something that we would like to avoid or treat as soon as possible if it really happens. So welcome for the seminar, and we're waiting to hear from you.
Thank you, Ruchira. So is the PowerPoint visible?
Yes.
Okay. So thank you, SPCTT, for inviting me to talk on chronic GvHD. I have a hard stop in an hour's time, so I may leave early, but I'll try as much as possible to deliver the important messages regarding chronic GvHD. I want to start with a disclaimer that I'm not an expert in chronic GvHD because we don't see extensive chronic GvHD in Wadia Hospital. So I want to start with that disclaimer. Having said that, my talk will be about chronic GvHD, and it is more geared towards how to think. And so it is targeted towards junior BMT physicians, how to think about transplantation. So I'll cover a bit of a history of GvHD, because without understanding history, you cannot understand the subject. And then I'll discuss briefly about role of thymus and transplantation. Most transplant physicians, they come from a hematology background and don't really pay much attention to thymus. But thymus is the most important organ in transplantation. If you don't understand thymus, you cannot be a transplanter. Then we'll talk about T cell role in GvHD, T and B cells in chronic GvHD very briefly, and then I'll end up with recent treatment advances. So most of my talk will be not from the textbook. It will be most likely from personal experience, personally how I see transplant, and some aspects of it will be where the textbook ends. So, transplant started in US in 1950s, and in the beginning, they started with sibling transplant as well as alternate donor transplantation. But they only saw success in identical sibling. And we all know the answer to that. Why did they see success only in identical sibling? But then they didn't know the answer. Okay, what they saw in non-identical transplantation or transplantation from non-sibling family donors is what they saw: GvHD and graft rejection. They gave different names to GvHD like wasting syndrome, etc. Well, this was in 1950s. But then in 1960s, there was discovery of dog leukocyte antigen and subsequently human leukocyte antigen. That's when understanding of T cells, adaptive immunity improved significantly. So 1960s was the era when we started understanding more about HLA, MHC interaction, and adaptive immunity. And this really helped us deal with the disease of GvHD. So the discovery of HLA led to the understanding that there is crosstalk between antigen-presenting cells and the T cells. So, and the crosstalk is through MHC HLA. So here you can see that CD4 T cells crosstalk with antigen-presenting cells to MHC class 2, and CD8 T cells crosstalk with antigen-presenting cells to MHC class 1. And this is the key to transplantation. This is very important to understand. T cells cannot function on their own. And so without antigen-presenting cells, T cells are basically useless. They will stay naive all their life and die. When it was understood, when the role of T cell in graft versus host disease was understood, that's when people started thinking about agents that could potentially eliminate T cells. And methotrexate was the first agent that they used in a dog model and showed that using methotrexate could prevent GvHD in a proportion of subjects, in a proportion of experimental animals. So this is when the penny dropped. And following methotrexate in 1970s, then we know that there are other molecules such as cyclosporine, ATG, alemtuzumab, and the list goes on that we use to eliminate or immunomodulate T cells. So the background is very important to understand. And now, having discussed a bit of history, most hematologists that when I trained, this is going back 10, 15 years ago, okay, did transplant in a way that they did conditioning and they put the cells in, okay. And this is a time when the transplant was really evolving, and the transplant came from the specialty of hematology rather than specialty of immunology in the UK at least. And so the standard way of doing transplant then was you give chemotherapy, radiotherapy, and you put the graft in, and you hope for the best. Okay, there was very little understanding about the role of T cells in transplant. In fact, transplant was never thought to be an immunology specialty going 20 years ago. And that was the time when people started really thinking that this is an immunology specialty, and if we have to improve this specialty, or we have to improve the outcome, we have to think like an immunologist. Okay, so it is very important to understand that when we are putting the graft in, the two very important cells that go in with the graft are the stem cells and the T cells. All other cells eventually die and have no implications. Okay, so as you can see here, I've shown HSCs and I've shown T cells that are long-lived. And T cells are very long-lived, and because they are long-lived, they have the potential to cause harm and the potential to cause GvHD. So the graft T cells are egressed from the donor's thymus. They are not meant for the recipient body. And because they are egressed from the donor thymus and are not meant for the recipient body, they are inherently alloreactive. And this is an important thing to understand. The T cells that grow in with the graft, they are long-lived, and that's why they cause GvHD. Whereas T cells that are egressed from the recipient thymus, which happens at the time of thymopoiesis, which takes place somewhere between 3 months to 6 months to sometimes 9 months or even a year in an adult, those T cells are meant for the recipient body. These are selected for the recipient body. And these T cells are tolerized. And therefore, these T cells do not cause GvHD. So it's very important to understand that whose thymus have the T cells egressed from is very important. So if the T cells are regressed from the donor thymus, which are the T cells that are coming from that go in with the graft, they cause GvHD. They are alloreactive, and therefore elimination of graft T cells is the essence to prevent GvHD. And how do you eliminate graft T cells? You use ATG, alemtuzumab, PTCY, and that's why it is very important to get this step right. In addition to elimination, it's also important to prevent proliferation of the surviving T cells that go in with the graft. Okay. So how do you do that? You prevent proliferation by giving cyclosporine, methotrexate, MMF, or abatacept. And what happens when, after 6 months, when the thymopoiesis starts? The T cells come from the recipient thymus. These are selected for the recipient body. And these T cells then do not cause GvHD, which is why you can then start tapering your GvHD treatment or GvHD prophylaxis. And that's precisely the reason why in bone marrow transplant, patients do not need long-term immunosuppression. Whereas in solid organ transplant, the T cells egressed from the recipient thymus will always see the solid organ that is implanted into the transplanted into the recipient as foreign. And therefore, solid organ transplant patients need long-term immunosuppression. So, having understood the role of thymus in transplantation, we'll then move on to understanding a bit about cellular mechanisms of chronic GvHD. So, in transplantation, transplant planning is very crucial. And the first step of transplant planning is immunomodulation of graft T cells. How do you tame those graft T cells? Or how do you eliminate those graft T cells? Or how do you deplete those graft T cells, which I discussed a little bit in the previous slide. So that step is very important. In addition to that step, if you have thymic disruption, which is like if you have severe acute GvHD, and that leads to thymic injury, or thymic injury because of chemoradiotherapy, and or in an adult where the thymus is not that functional. If you combine the two, which is you have deficient immunomodulation of graft T cells as well as thymic disruption, that is when you have severe chronic GvHD. That is when you have problems of chronic GvHD. If you can manage one step, so if you have only deficient immunomodulation of graft T cells, but your thymus is good, then you shouldn't see chronic GvHD. Or if you immunomodulate your graft T cells and your thymus is not functioning well because of whatever reason, you should still not see chronic GvHD. Okay. So GvHD is basically effector regulatory imbalance. And chronic GvHD is severe deficiency of T regulatory cells. So here in a cartoon, I've shown when you have thymic disruption, there is impaired T cell selection. And impaired T cell selection means you have reduced production of T regulatory cells. Impaired T cell selection means the T cells that are selected are not selected enough quantity. That leads to reduced production of T regulatory cells. And reduced production of T regulatory cells mean that the effector cells that have survived, that went into the graft, they are more compared to the regulatory T cells. So the effector T regulatory balance is not restored for a long time. And that dysregulation then leads to chronic GvHD. So the sooner you can regulate that effector T regulatory balance, the chance that your chronic GvHD resolve early is much higher. And this is typically what happens with cord blood transplantation. When you do a cord blood transplantation, the risk of chronic GvHD is much low because the T cells that go in with the cord blood, they have ability to regulate themselves in the periphery. Okay. So the T cells that go in with the cord blood, T cells can proliferate very robustly, and which is why when the effector T cells proliferate, the T regulatory cells also proliferate, therefore restoring balance, and therefore reducing the risk of chronic GvHD. In addition to that, cord blood T cells also possibly have potency to sort of help with early thymopoiesis. So these are the two reasons why you don't see significant chronic GvHD with cord blood transplantation. Whereas with peripheral blood stem cell transplantation, if you get one of these steps wrong, then the risk of chronic GvHD is very high, which is why it is essential to get at least one of these two steps right. I mean, the second step is not in our hand, which is thymic disruption. We can't do much about it. But the first step is definitely important. And by doing proper transplant planning, you could then immunomodulate graft T cells and reduce the risk of chronic GvHD. Is there a role of B cells in chronic GvHD? Maybe there is. I don't know for sure. I mean, effector T regulatory imbalance could possibly lead to activation of B cells. And this then could produce clones of B cells that could then potentiate an autoimmune disease, which could lead to chronic GvHD. But the key step is restoring T effector T regulatory balance. And then if you can restore that step, the B cells will automatically not be able to become dysfunctional. But if you have got effector T regulatory imbalance, then there could be B cell dysregulation as well. And then that could lead to a much more severe type of chronic GvHD. So maybe there is a role of B cells as well in chronic GvHD. So as I said earlier, transplant planning is very crucial. Chronic GvHD in children is largely preventable. Okay. If you do your transplant planning properly, the risk of chronic GvHD in pediatrics should be very, very low. No child less than 12 years with non-malignant disease should develop extensive chronic GvHD. I mean, that should be the aim of any good transplant center. No child less than 12 years with non-malignant disease should develop ocular or genital GvHD. In children less than 12 years, chronic GvHD largely reflects suboptimal transplant technique. In malignant disease with residual disease burden, chronic GvHD may be acceptable. Because there you possibly want graft versus leukemia effect. So how do you prevent chronic GvHD? Or how do you prevent GvHD? I mean, those methods are there now. Alemtuzumab for non-malignant match-related or unrelated transplant, which we regularly do, and I can't see why everybody can't do it. The technique is foolproof. UK has been doing it for years. Appropriate T cell dose, appropriate ATG dose, as parachute trial has shown. If you can't use alemtuzumab, use appropriate ATG dose, as the parachute trial from Netherlands has shown in match-related and unrelated transplant. And if you're doing PTCY, it needs to be refined in a way that the risk of GvHD is low. So, for example, what Suparna Chakrabarti has shown, use of abatacept with or without ATG. I mean, those are the refinement that need to happen so that we don't see children with chronic GvHD. And of course, the risk of GvHD or chronic GvHD with alpha beta depletion and memory T cell top up in haploidentical transplant is very, very low. We haven't really seen one. So my experience of GvHD didn't start with humans. My experience of GvHD started with animals when I was doing my PhD, and I was infusing cord blood T cells and peripheral blood T cells into mice. As you can see here on the left-hand side, when you put peripheral T cells into the mice, they start losing weight after 2 to 3 weeks, basically because they get xenogenic GvHD. Whereas with the cord blood T cells, nothing happens to them. And on the right-hand side, you can see liver and skin in the two groups, in the mice that have been injected with peripheral blood T cells and the mice that have been injected with cord blood T cells. And this is the reason I put this slide, because this taught me that GvHD is a T cell disease. That was my first lesson about GvHD. If there are no T cells, there is no GvHD. And this is very important to understand, and I'll explain to you why in the next few slides. So this was me as a consultant, as a new consultant, sitting with hematology transplant physicians. And there was good practice in the hospital I was working that we used to sit across with the histopathologist and look at all our biopsy samples, whether it was whether it was to do with the gut biopsy, liver biopsy, or whether it was to do with the bone marrow refined biopsies. So it was good practice in that center. And one day we were seeing such sample. Okay, this was all typically a gut biopsy of a post-transplant patient, and the histopathologist said, "Oh, there is apoptosis with macular degeneration, and therefore this is grade 2 or grade 3 GvHD, whatever histopathology grading they had at that time." And my question to them was, where are the T cells? If you're calling this GvHD, could you please show me where the T cells are? And that is an important question to ask to every histopathologist whenever you send samples. Okay, if you want to label a histopathology sample as GvHD, you should have T cells there. Unfortunately, the histopathological grading of GvHD does not take T cells into consideration at all. So this is the histopathological grading of GvHD, which says loss of crypts, loss of vacuolation, or total denudation or ulceration, but it does not talk about T cells. And if you add fibrosis to this histological grading, it should apply to chronic GvHD as well. So the point I want to make is, if you're looking at histopathological sample for the diagnosis of GvHD, it is very important to know whether there are T cells on it. Because there are many pathologies that can masquerade GvHD. And it is important to delineate whether this is GvHD or not a GvHD. Because if this is not a GvHD and this is an infection, or this is a drug-induced toxicity, and you're treating it like a GvHD, you are never going to win. So it's very important to understand that. So only a GvHD should be treated like a GvHD, and everything else should be separated from the GvHD. So what pathologies can masquerade as GvHD? Infections, of course, and viruses, pseudomembranous colitis, different medications. I mean, mycophenolate mofetil is one of the common drugs that we use routinely in Vade Hospital. And we know a number of times that it can present like colitis and gut symptoms. So it is very important to keep in mind that drug toxicity can masquerade as GvHD. Of course, methotrexate can as well. And thrombotic microangiopathy could be a mix of both GvHD as well as TMA. But another important pathogen to remember, especially when you're dealing with liver GvHD, is Cryptosporidium and drug-induced liver injury. So these two pathologies, you have to rule out. I mean, you really have to rule out all these pathologies before you label something as GvHD. So diagnosis of GvHD is very, very important. You have to use clinical pathological correlation, immunohistochemistry, look at whether patient has got circulating T cells, look at whether T cells are there inside the histopathological specimen to make a definitive diagnosis of GvHD. So having said that, I'll move to case 1. So this is a relapsed B-cell patient with IAMP21 referred to us at relapse. Post-induction MRD was 0.15%. Complications during treatment of during R3 was appendix perforation and had grown Pseudomonas aeruginosa in the blood culture. Patient received blina consolidation with us because MRD was 0.15%, became MRD negative, and then underwent matched sibling donor-born hematopoietic stem cell transplant. It was PBSC, was TBI etoposide, which is standard, and GvHD prophylaxis was cyclosporin and MMF. Unfortunately, developed mixed chimerism very early on. At day 20, the chimerism was mixed at around 94%. A repeat chimerism 96% on day 24. So at this stage, we stopped cyclosporin, and we did a bone marrow around day 30. And on day 30, the chimerism, CD15 chimerism was 88. So it was very low according to us. And had it been 95, 96, we would have possibly waited and done nothing. But because it was less than 90%, we thought maybe this patient is at risk of relapse or losing the graft. And therefore, we gave 1 × 10⁷ DLI on day 34. And the patient reverted to 100% donor chimerism in a week's time. So I don't know whether the DLI played a role in reversion of chimerism or whether just the stopping of cyclosporin did. So one could argue on that, but that's not the key point here. So this patient had received DLI, and I think by day 45 to day 50 developed lichenoid lesion in the mouth, was clearly DLI-induced lichenoid lesion, because we don't generally see lichenoid lesion in the setting where we use serotherapy. So DLI possibly had a role in this. So what are the clinical patterns of chronic GvHD? The classic clinical patterns of chronic GvHD are lichenoid lesions, dry features such as Sitka features, ocular dryness, bronchiolitis obliterans, upper gut GvHD in the form of esophageal webs, sometimes genital GvHD. So these are classical features of chronic GvHD. And this patient had lichen planus, so maybe this patient could be classed as chronic GvHD. So chronic GvHD is not necessarily classed based on whether it happens before day 100 or after day 100. It's mostly classified based on what features does the patient have. And there can sometimes be overlapping features of acute and chronic GvHD. But that's all theory, really. I don't want to dwell too much on theory. So what happened to this patient subsequently? So subsequently, this patient developed transaminitis. So you can see here SGPT and gamma GT, which is shown in red and blue. Around day 75, developed transaminitis with slightly high bilirubin. So this baseline bilirubin 0.3, and then it gone to 0.6 here. So was treated with a short course of prednisolone or resolved. And then subsequently, again, around day 250-ish, started to develop transaminitis. Both gamma GT and SGPT started to rise. I mean, gamma GT had gone as high as 1600. And it was quite worrying. And it was rising, every day it was rising by 200, 300. So given the background of lichenoid features before, and that the patient has had received DLI, and the patient was thrombocytopenic at this stage, when this episode of transaminitis and hyperbilirubinemia happened. And this episode of transaminitis was not responsive to ruxolitinib. And the patient was also on other immunosuppressants such as tacrolimus and prednisolone. So it was not responsive to any of this. And the gamma GT was rising by 300, 400 every day. So we rushed into giving this patient alemtuzumab. At that time, patient has reasonable number of CD4, CD8 T cells. So again, could be GvHD. We didn't do biopsy because the patient was severely thrombocytopenic and platelet count was 20. And we had a strong suspicion that this could be GvHD because of the past background. After alemtuzumab, transaminitis reduced nicely, and we thought we were winning. Subsequently, the patient got discharged, but then came back coming with recurrent infections, recurrent hyperocalin fever. And the patient was on 4 immunosuppressants at that time: prednisolone, tacrolimus, sirolimus, and ruxolitinib. The patient had an episode of Pseudomonas bacteremia around day 375, and following that, patient had acute pancreatitis with high lipase and amylase. And the CT scan showed necrotizing pancreatitis with gallbladder sludge and pseudocyst. Again, we saw same findings, that the patient had transaminitis and patient had GGT rising as well. So here we treated patient conservatively, like you treat any acute pancreatitis, and the SGPT went down, GGT sort of reduced. And we also decided that at this stage, because of acute pancreatitis, we thought it could be secondary to sirolimus, so the sirolimus was stopped. And we also decided at this stage that this patient has got too many liver factors. I mean, initially we diagnosed him as liver GvHD without a biopsy, and the patient came with acute pancreatitis. We don't know what really is going on with this patient. So eventually we reduced his prednisolone, tacrolimus, and ruxolitinib and stopped everything. Patient had another episode of pancreatitis, and at this stage we did MRCP, and the MRCP showed hepatomegaly, periportal edema, and again features of chronic pancreatitis. So at this second episode of pancreatitis, again the gamma GT was up, but the SGPT was not up in this episode, and there was some small rise in bilirubin as well. So when we looked at his imaging in total, what we found was that he had edematous gallbladder and a hyperdense gallbladder lumen. So this is what raised a suspicion, suggesting that could this patient have a localized infection here? Could this patient have cholecystitis, which is why he's coming with recurrent fever? He had past episodes of Pseudomonas sepsis. So it is possible that he may have localized Pseudomonas there, and that could have now led to chronic cholecystitis. And which is why all of these elevated gamma GTs could be the reason, as well as acute pancreatitis could be the reason for the same, because the gallbladder sludge could then backflow into the pancreatic duct and could lead to acute pancreatitis. This was the thought process at that point of time. And then soon after this, he came with an episode of right hypochondrial pain. And we said, enough is enough. I think we have to take this gallbladder out. So we did cholecystectomy. And the cholecystectomy showed evidence of chronic cholecystitis. We also did liver biopsy at that stage. There was no evidence of liver GvHD at all. So in retrospect, we don't know whether we were dealing with liver GvHD in the first place, or we were dealing with some element of cholecystitis throughout his episodes of transaminitis that we were seeing. The difference between the previous episodes of transaminitis and the latter episodes of transaminitis is that SGPT was not elevated in the latter episode, whereas previous episode SGPT was elevated as well. So the reason I discussed this case, because we didn't do liver biopsy when we intensified his immunosuppression, and maybe we should have. The reason why I didn't do liver biopsy, because his platelets were very low and we thought he is at risk of bleeding, and there's a very good background. He had lichenoid lesion in his mouth. He had liver, and he had received DLI. So all could fit nicely with GvHD. And so therefore we treated him like a GvHD without liver biopsy. And maybe in retrospect that is not correct. So that's the reason why I presented this case. Now moving on to case 2. I know we are short of time, so I'll finish in 10 minutes. Moving on to case 2, this is a case of Fanconi anemia, who was treated with fludarabine, cyclophosphamide, alemtuzumab, rituximab conditioning, was transfusion dependent, received our standard protocol. At day plus 60, developed diarrhea, stage 2 diarrhea, according to GvHD grading, GvHD staging. And we did a GI biopsy. GI biopsy showed usual histological features of graft-versus-host disease, but also showed T-cell infiltration 70%, 60% in ileum and colon. So we were quite convinced that this is gut GvHD. We treated initially, we optimized cyclosporine, and then we treated with methylprednisolone. We tapered methylprednisolone. As we tapered methylprednisolone, the symptoms came back again. So therefore, we started ruxolitinib, and we continue treatment with ruxolitinib. So if a patient is not responsive, or if a patient has got steroid responsive GvHD, you can't keep giving steroids again and again, because it's good to put them on an alternative treatment like ruxolitinib or maybe MMF, if that suits the patient. So here we treated with ruxolitinib. And the question when you're putting patients on immunosuppression, when do you start tapering the immunosuppression? Although this patient is not a classic case of chronic GvHD, the reason I put this case is because when you have got patients on too many immunosuppressants, what do you do? How do you deal with too many immunosuppressants? So the first immunosuppressant that you taper is the steroid, and you taper it to a level where the GvHD is controlled. So generally you want to taper to a level of 0.5 milligram per kilogram. And if you can get patient off methylprednisolone completely, nothing like it. But if you can't, leave it at 0.5 milligram per kilogram and do nothing after that. Leave the patient on remaining immunosuppressant if there is no evidence of infection, especially in chronic GvHD. But then when do you taper? You wait for some T cell recovery. You wait for some thymopoiesis. So here you can see I've showed naive T cell recovery as well as thymic emigrant. So when you start seeing naive T cell recovery, that's the time we started tapering ruxolitinib. And you monitor and you see, yes, the T cell recovery is happening nicely. You're getting thymopoiesis, treks are coming out nicely. And then you're more confident that this is now an immune system that will be tolerized. And then you can take patients eventually off immunosuppressant. So that's the reason why I put this second case. And the third case is very quick. A boy with congenital omega-karyocytic thrombocytopenia. Again, standard transplant regimen of ours with alemtuzumab serotherapy and a match-unrelated donor. Developed very dry skin from day plus 60 onwards, was not responsive to topical steroids and calcineurin inhibitors. And the patient had this. Is it GvHD or not? I'll let you think about it. So to summarize, GvHD treatment hierarchy is very, very simple. Most important thing, confirm diagnosis before intensifying immunosuppression. Do not intensify immunosuppression without confirming a diagnosis of GvHD. Your basic treatment of GvHD is calcineurin inhibitor and steroid. If that doesn't work, ruxolitinib. And if that doesn't work, you can pick up whatever you want. You can use mycophenolate, etanercept, infliximab. There is no right answer. And be patient. And if nothing works, then you go into experimental treatment like ATG, alemtuzumab, mesenchymal stem cells, whatever is available to you. But the best strategy for GvHD is prevention. Now, having discussed that, I want to discuss, this is what many of you will be interested in. Are there any new drugs in GvHD? The only new drug that is there in GvHD is ruxolitinib, and we all know that. But are there any other new drugs in GvHD? So I will lay this for you, and then I will let you make your own conclusions as to whether there are any new drugs in GvHD or not. Okay. So the new drug in chronic GvHD was ibrutinib in 2017. FDA gave approval. FDA gave approval on the basis of 42 patient study. This was a single arm open label study. Okay. European Medicines Agency hasn't approved it. And it's still pending as a orphan designation since 2016. Okay. So there must be a good reason why EMA hasn't approved it. Yeah. So it's very questionable whether ibrutinib has a really meaningful role in GvHD. What that means is there may be a small subgroup of patients where ibrutinib may be useful, like patients who got definite evidence of B cell activation. For example, if you have patients who got very high B cells, or if you got patients who got very high immunoglobulin levels and has got GvHD, those are the patients you may want to consider ibrutinib. But to consider ibrutinib in a B cell deficient patient or a patient who's got very low immunoglobulin levels, you have to think twice. Yeah. And then the next drug, which is belumosudil. belumosudil was approved on the basis of 65 patients who received 200 milligram daily dose. Okay. Again, EMA hasn't approved it. And EMA hasn't approved it because in the belumosudil trial, patients were treated simultaneously with many other drugs. And a study that examined belumosudil as a first line for chronic GvHD failed. Okay. So again, use of belumosudil is questionable, but maybe there is a role of belumosudil in fibrotic sclerotic GvHD. Okay. And then the third drug, which is the recent FDA approval in 2024, was approved after the phase 2 study of 79 patients. So unlike the other drugs that target the T cell pathway, this drug targets macrophage pathway. So we still have to wait and see whether these drugs stand the test of time. Yeah, there are active clinical trials still ongoing in the EU, and with time we'll come to know how good is this drug. And so those are my takeaways about the recent FDA approvals. And any time when FDA approves the drug, best way to look at whether that drug is applicable to your patient population is to read summary basis of that approval for that particular drug. So there is a document called summary basis of approval. So that is a document that you should read to understand whether that drug is applicable to my patient group or not. So what are our chronic GvHD outcomes in YDA Hospital? So we are not a big transplant center, but over a period of time, our transplant activity has gradually improved. We are not looking to do. We are only looking to increase 5 to 10 transplants every year. So we're gradually moving towards 50 this year. But having done so many transplants over a period of time, we've only seen 8 patients with limited chronic GvHD, and we have not seen any patient with extensive chronic GvHD. So that's why my disclaimer that I'm not an expert in chronic GvHD. So the key takeaways: always think times. GvHD is a T cell disease. Chronic GvHD should be a very rare pediatric disease in any transplant center. If you're seeing a lot of chronic GvHDs, you have to refine your transplantation techniques, because if you're seeing chronic GvHD in pediatrics, you're not taking advantage of the thymus. Prevention is the best way. Always confirm the diagnosis before intensifying immunosuppression, and question the diagnosis if your ruxolitinib fails. So with that, I will conclude. I was going to talk about the future, but I think I'm short of time, so I'll skip this slide. Thank you very much. Thank you, everyone.
Thank you, Prashant. Over to Ruchira for any questions.
Excellent presentation, Dr. Hivarkar. 2 takeaway points that I would like the residents and the PG students to really understand is that chronic GvHD does not mean that it comes after day 100, which is first case was highlighted very well in the first case where it appeared around day 50 itself. And secondly, a point which is quite well stressed on during the presentation is that the need to confirm your diagnosis before you jump onto using second, third, fourth agents for chronic GvHD. My first question, Dr. Hivarkar, is that when you're doing a T cell deplete graft, do you think about CD3 doses to define your T cell doses? And how do you choose the cell dose in our patients where you're thinking of haplotransplants?
So the only haplotransplant that we do, so that I don't know if you're talking about match related or only haplo. Is your
mainly haplo? Mainly haplos.
Yes. So if you're talking about haplo, so the only haplotransplant that we do is alpha beta deplete transplant. We don't do PTCY in our center. And we cap that as 1 times 10 to the 5 per kilogram of the alloreactive T cells or whatever T cell that go in with the graft. And then we give memory T cells following that. It's not very clear to us that whether the memory T cell should be given on day +1 or whether they should be given after the graft goes in. So that practice is still not refined yet. The reason why that practice we think is not refined, because if we give memory T cells on day +1 and if there is a CMV reactivation, let's say day 8, day 10, then whether those memory T cells could start the process of macrophage activation or graft rejection is not very clear to us. Which is why I think we have now resorted to the practice of giving memory T cells after the graft is gone in and we're seeing good neutrophil count. That's when we give memory T cells.
Also, any biomarkers that you would suggest or you think would be important in trying to detect GvHD, especially chronic GvHD?
So there are many biomarkers, and there are many biomarkers which people are working on to understand, to predict who will get chronic GvHD so that you can start treatment early, etc. But no one biomarker is foolproof. And so for that reason, I don't think there is a biomarker that really is helpful as it stands today.
Satya sir, any questions from your end?
So I would encourage people who are logged in to text message, and we can take those questions. Meanwhile, I have a question for Dr. Prashant. Excellent overview of chronic GvHD and the basics you discussed. That was absolutely wonderful. So my question is that as we are doing more and more haplo-PTCY transplants in India with peripheral blood stem cell as the graft, so we are seeing a higher rate of chronic GvHD in most centers, ranging from 20 to 30%. Although the systemic data from India is not available, and because in your center you're not doing PTCY, that's you have already told us, but still, any thoughts you have on peripheral blood versus bone marrow as a graft in general for chronic GV for transplant in children, and anything you would like in haplotransplants, peripheral blood versus bone marrow? Thank you.
Yeah. So certainly, I mean, the traditional wisdom is that peripheral blood stem cells graft causes more GvHD than bone marrow graft. That's the traditional wisdom, because the T cells carried, the T cells that go in with the bone marrow graft are less in quantity compared to the peripheral graft. So my second sentence is very important. If you can control for T cell numbers, then whether you use bone marrow graft or whether you use peripheral blood stem cell, it shouldn't matter. Okay. So the first step to reducing the risk of GvHD is controlling for T cells. Okay. So any center that is doing n number of PTCY, they first need to start looking at what number of T cells are they putting in these patients, and is there any correlation between the T cell that they put in and the GvHD that they see. So that is the first thing to do. In addition to that, I think there is a role for abatacept. I mean, Suparna has shown it quite nicely, even in pediatrics. There is possibly a role of ATG, definitely in non-malignant transplant with PTCY. So all of these refinements, if you do to PTCY regimen as well, I think PTCY will have similar outcomes to alpha beta diplet haploidentical transplant. It's a question of doing it systematically over a period of maybe 2, 3, 4 years. Maybe few centers who do PTCY regularly should get together, plan a protocol, do all their graft analysis in one center, like for example, one path lab. So you know what T cells are you putting into that particular patient. So that would be a starting point, and then refine over a period of time, adding abatacept, adding ATG. I think those are the refinements that need to happen in PTCY, and that will reduce your risk of GvHD substantially.
So thank you for your input. So there is one more question which I think is very relevant for all the people who are logged in. If you'd like to tell the people who are youngsters that uh, like when you have chronic GvHD onset and a patient is not in your direct follow-up, they have gone back to their own hometowns and home countries, uh, then how to ensure that the GvHD of the joints it is picked up early before it becomes too late and they have all the disability and walking difficulty and sometimes they can become bedridden. So how to go about it, what instructions they should give to pediatricians or in the handover letter when they are sending the patient back to community. Thank you.
Yeah. Yeah. So so this is very easy. I mean, I think there are two aspects to it. You can give in writing to the doctor, but you can also train the patient. So I don't know when the patient goes in the community to a different country, do you have video consulting with them or you completely stop? My suggestion would be that you should own that patient, even if the patient goes anywhere, say to a different country. I mean, a 5 minute of video consulting doesn't hurt if that is going to improve patient outcomes. There is a way in which you can pick up joint involvement very early. So there is a technique which I don't use now. I used to use like 10, 15 years ago, that there's an exercise that you ask patient to do something like this and different other techniques. You can teach the patient. If they are not able to do this properly, then that suggests early joint involvement. So there is a method in which you can diagnose it quite quickly. So if you're really going to break connections with the patient and patient is going to go away, you should maybe, and the patient is a risk of significant risk of chronic GvHD, especially because they've had PTCY, then you could train the patient and say, look, at the earliest sign of this, they need to contact you, so that you can then start physiotherapy early, and maybe you can then start drugs early as well.
So yeah, thank you. This is again very relevant for everyone. Early pickup of joint involvement is something very, very vital, and teaching patient and the physicians who are going to look after them how to examine the joints regularly. And at the earliest onset, they should be referred back to the BMT center. So I think one more question is there in the chat box. Ruchira, you want to ask that question?
Yeah. Dr. Hibarkar, we have a question which asks for the use of alemtuzumab versus ATG for GvHD prophylaxis in India. So it's specific to India. Where do you think ATG stands and where do you think alemtuzumab should come in?
See, one thing I want everybody to get out of their mind, that whether it is India or whether it is any other part of the world, it's the same thing. It's to do with your mindset. Okay. We have to change our mindset. Otherwise, we will always think India versus West. No, it's not. Of course, if you are using ATG or whether you're using alemtuzumab, you have to do viral monitoring. There is no way you can do good transplant without viral monitoring. Okay. Now you have to find ways of how you're going to do that viral monitoring cheap. Okay. So I'll give you a tip. So the starting point is you have to know which viruses happen when. Okay. So EBV monitoring, you can maybe start after 2 months, because generally before 2 months, you don't see EBV. Okay. If you want to save the cost. CMV monitoring is essential. You have to continue that. Adenovirus monitoring, you can start with any evidence of diarrhea. Okay. So you can fine tune it to your own system. Yeah. So West or India doesn't matter. I mean, whether you use ATG or alemtuzumab, you have to do viral monitoring. You only have to find a way how to do intelligent viral monitoring. We are lucky in a way that we get subsidized costs from various centers in various hospitals. So we can even do twice a week viral monitoring.
Something we are not.
So Prashant and Ruchira, I think because of lack of time,
I'll ask only one question to you. When you say that Tregs are there, is number we can comfortably say that patients come out from chronic GvHD? Does any numbers are there? Tregs?
No, there is no number. So it's not that when you start seeing thymopoiesis or naive T cells, you stop their GvHD treatment completely. It tells you that now you can start tapering their GvHD treatment gradually. And then you keep on monitoring their T cell recovery. If you see that naive T cells are coming up nicely, then that tells you that the thymus is recovering. And so you're much more confident that the relapse of GvHD is not going to happen.
So I will ask everyone to end this session here, because we have the next panel discussion, which is going to cover a lot of questions which are coming up. So thank you, Prashant, for a wonderful talk, and thank you, Ruchira, for chairing this session. And we finished the talk part, and now we move over to the second part. Thank you, both of you.